How's everyone doing? Good. As mine Anthony really illustrated, I think good things happen when you partner up between payer and hospital environments. You get a chance to talk and collaborate, and it's pretty illuminating when that happens. And without further ado, I want to introduce some good friends from Legacy Health System here. You've heard of the expression, the hardest working man in show business, the person who never stops. I think that might be Nate.
Oh, wow.
Nate Semm is a social worker, but there is quite literally not one aspect of the Legacy environments that he doesn't go to. He covers the waterfront. He's in all of them. And joining him today, his partner in crime, is RN Case Manager Extraordinaire, Elizabeth Decker. RN case managers don't do a lot of work, though, do they? They're just kind of calmly checking their phones, looking at email. Nothing really ever happens that's exciting in their world. But we're going to hear a lot of good stuff about case management, challenges, and successes from our friends here. So please warmly welcome Elizabeth and Nate.
This guy, he is a flatterer, right? Should be in show business. So yeah, we're part of the care management team. I am a system-wide float, which is a new position to the Legacy system. They have identified that they actually like social workers enough that we want them all the time. So they move me around to all of their sites. I work on all the floors. The only site I haven't gotten to yet is Salmon Creek, so I can't speak to them. But we work closely with our buddies, the nurse case managers. They do all of the wonderful medical and, yeah, all that stuff that I don't understand. Yeah, the home oxygen and the wound care, and they handle all that part that I don't even understand. We talked about language earlier, and that's absolutely true. So, yeah, so I just wanted to see what people's, I heard a little bit of rumblings before, but you know, this might be a perception that you all have of what we do. It is false. It is false. You know, we'll talk about some of the challenges and experiences that we have so that you can kind of see what it is that we deal with on a daily basis. So it is a process, and it does happen quickly. There's a lot of reasons for that. It starts by having an assessment done by the social worker and or nurse case manager. Sometimes both of us are doing assessments because especially the complex people that we're kind of talking about need angles from both. The social worker I can speak to at least. We tend to be strengths-based and trauma-informed because that's our general practice, trying to figure out what this person has that we can build on to make a plan that's going to work for them. We have interdisciplinary team meetings pretty much on a daily basis, depending on the unit, to discuss, hey, where are we going with this person? What can we do? How can we get them there? We do try and include family, personal choice, and community supports if possible. We talked a little bit earlier about the cultural competence and especially wanting, you know, the recommendation probably was for a skilled nursing facility, but that didn't happen. People do have that autonomy, which frustrates us to no end on a consistent basis. You know, so there's oftentimes a lot of motivational interviewing or cajoling or bribery, whatever you want to look at, to try and get them to consider that as an option. Our average length of stay throughout the Legacy system is 4 to 6 days. It's a little lower at Meridian Park, but across the board, that's kind of our average length of stay, just system-wide. This is one of the key points. We're not supposed to keep them longer than medically necessary, and that does change hospital to hospital, physician to physician, floor to floor. Some doctors are a little more willing to stretch that out and find something if we're trying to create a plan or make something happen together. But if we don't have any kind of a plan, or we're just frustrated, we can't figure anything out, you know, the doctors are ready to let them go. And we saw behavioral determinants a little bit earlier in one of the presentations. That absolutely plays into this. If somebody has behavioral problems in the hospital, I can guarantee you they will get discharged quicker than if they're quiet, easy, and compliant. We do approximately 5,300 discharges per month across the legacy system, and care management works with a little over half of those. The ones that we don't touch are often the med-surg patients that come in for planned surgeries, and they just go home the next day or the same day because they don't have needs, or the plan has actually been pre-thought of and just needs to be executed. So
I thought I would go in a little bit about the history of
Yep.
care management.
Yep.
Especially with legacy, it was about in the fall of 2014 we adopted this new model. Before the care management department was just made up of anybody that wanted to do discharge planning. So in about 2014, legacy developed this model about bringing on RNs, so any licensed practitioner, and then social workers. And we also, with assessing our patients, we, as case managers, go in and look at every patient that comes in. Prior to that, we would just wait for a doctor or a nurse to put in an order for case management, social worker, and then we'd go off of that. But now we're basically touching everybody. If I'm assigned 24 patients, I'm going in and looking at all those patients and identifying if there's any needs early on within 24 to 48 hours. That's our goal, is to do that.
Yeah.
And then a big focus now is avoidable days. Patients are here, they're medically ready to leave the hospital, but what's keeping them in the hospital? Social reasons, placement, and all those things. So that's why our average length of stay kind of can vary.
Yeah, and it certainly varies floor to floor. I mean, when I work on the trauma recovery unit at Emmanuel, length of stay there is way over 6 days. Like almost everyone there. We'll get to a few of the outliers a little bit later, but we actually now have a length of stay, long-term care team at Emmanuel for people who are there 30 days or more, and those are our really complex discharges for a variety of reasons. This kind of is just a little graph that Melanie Westrick, our supervisor, kind of has and presented. Just kind of gives you an idea about where people go when they discharge. SNF obviously is our biggest piece of the puzzle. Mm-hmm. We work very closely with a number of SNFs, and I think that's really improved things. Marquis was just at Emmanuel yesterday telling us how much lower our readmission rates have gotten since we've started working with them specifically, just because we're working more closely with them and we're able to kind of really delve into and analyze the problems that we're seeing and try and prevent some of those readmissions. They have some reps at some of our sites.
Yeah, they have on-site liaisons that work and come and meet with patients if there's some challenges, just to kind of smooth that transition. They have transition of care nurses that come and meet with the patients. They review the chart, look at their meds, look at their PTA med list, make sure that they're going out on those same meds. At Meridian Park, before they leave to a facility, either as it could be a skilled nursing facility or assisted living, foster home, we send a message to our pharmacists to review the meds and make sure that they're okay. A lot of times they're not okay, so it's keeping that communication open, and then having the skilled nursing facility also have that information.
Yeah, and then obviously the second biggest chunk is home with home health. That's not AMA. They're very close, but I want to make sure that those are different. So talking about the problems with home health, like we experience that all the time. The fact that a lot of them don't do any admissions over the weekend or things like that. That's part of why we discharge a lot on Friday afternoon. Another piece to that is it's really hard or impossible to get off for SNF on the weekend because, no offense, CareOregon, you guys aren't staffed. So we have to get them out Friday, or they're there until Monday, and they might be medically ready on Saturday or Sunday. So if we can't get that off done before,
keep them till Monday.
Okay. Well, we'll talk later.
Change our length of stay.
But yeah, that's something that we have noticed in our tracking is off sometimes. It's just the barrier, and it's totally avoidable the insurance companies across the board would just have somebody come in for a couple hours on Saturday or Sunday. So you told me to be candid. Yeah.
I'm going to punt it back to you. Has Legacy looked at beefing up staffing on the weekends, like the 5-star?
So,
plans?
yeah, so they're,
For authorization, or no?
For like case managers on the
Oh,
weekends.
we do have case managers on the weekend.
Oh, yeah. Oh, yeah.
20, or not 24 hours,
But-
7 days a week. It's not as, like our core staffing, like at Meridian Park is about 8 for the whole hospital. We go down to 3 to 4. That's excluding the emergency department. There's somebody there 12 hours. And then there's 3 in-house for our hospital. I don't know how the rest
every
are, but
hospital's
yeah,
a little different, but yeah, they
do have
definitely go
our
down,
weekends.
but we definitely have people who are there because there's people coming in on Saturday and people coming in on Sunday, and they, when they're medically ready, we got to have a plan ready. So, yeah. So some of the community partners that we have out there that have really helped us or that we find super helpful, shout out to Recuperative Care Program and CCC. I probably send 2 to 4 people there a week. They're like my favorite program. For those of you who don't know, they take people who are experiencing houselessness and don't qualify for SNF because they don't have any physical health rehab needs, but still need ongoing care for wound care or follow-up. And they give them a place to stay and some supervision and some support, and connect them with Old Town clinics so they can get the follow-up that they need. They are authorized through CareOregon, so it's one of the programs that just, as a social worker, this is the population that I work with, right? They don't call social work for the 44-year-old that has insurance and has a family and is going to be well taken care of at home. So shout out to them. We've made some headway with DePaul Treatment Center as well recently, where we can roll people pretty much straight into DePaul from our hospital system, because we kind of guarantee that they are ready for treatment and medically sound, which is there's a barrier for them sometimes. People come in, start withdrawing or detoxing, way too high level care for them. So we kind of have that sweet spot figured out, and they've been super helpful. We'd love to work more closely with CODA and some of the other inpatient people as well, because that's clearly a need for us. Again, the skilled nursing facilities, especially Marquis, for having liaisons, wanting to work with us, trying to create a good system to roll people out of the hospital with good plans.
And they actually attend readmission committee meetings once a month at the hospitals, review those patients of if they had to send anybody back within the 30 days of why and what they can do to improve it. They're also on like a pain management committee to help with that as well. So a lot of collaboration.
Aging and disability. Our hospitals now have workers from aging and disability that can come and do Medicaid screenings for higher levels of care at the various hospitals, and they're staffed fairly appropriately. There's one person that goes between Mount Hood and Good Sam, and then Emmanuel has one full-time person just because they're so huge. So that way we can try and get people directly into a higher level of care if they need it and get the funding that they need.
I think right now it's just Multnomah County, the hospitals that are in Multnomah County. So
Right.
Meridian Park, we don't have
Yeah,
this.
Meridian Park, they don't have it.
And
But that's
Salmon Creek.
Yeah, that's something that has been really helpful at those two hospitals, trying to get people the level of care and the funding sources that they need. Do you want to talk about the CCS pool, because you work right next door to them?
Right, so it's our clinical coordination specialists. With transitioning into this new model of care management, they were finding that a lot of our time was on the phone trying to set up bride to care or follow-up appointments, and totally not leaving us much time to actually work with the patients and coordinate their care to discharge. So they've created this pool. It's actually housed at Meridian Park. Right now it's 4 clinical care specialists. They basically do our appointments, our transportation, our SNF referrals, home health referrals, and they are like the the glue that keeps us going. So we
Yes.
just send them a in-basket message through Epic, and they get it all set up, and they're the ones that are actually talking to the doctor's offices, the home health agencies. So
Yep.
it's been a great, great program, and
Yeah.
I think it's helped streamline a lot of things.
They're fantastic. And we just started piloting them, arranging follow-up outpatient mental health appointments. So we're very, social workers are very excited about that. Mobile health also started at Meridian Park.
We piloted at Meridian Park. It's a partnership with Metro West. I don't know if people have heard of it. So they come out and see a patient once a week, and for the next 4 weeks to help decrease those readmissions. They kind of do an on-site. They're the eyes and ears. They help troubleshoot, see if they need to go back to their doctor's office instead of going to the emergency department. We have a lot of people that accept it. A lot of people don't say they don't think they need that service, but then the next time they do readmit, then they're like, I think I want that program. There is some communication.
Nope. They'll see whoever. It's
Yeah.
we have a contract, so they'll go see whoever. So they will meet some of our houseless people at Burger King to check in with them. Like, they will do whatever. They're super cool.
Do you have data about the success of that program?
We do. Melanie Westrick does. We just I didn't have time and space in the presentation, but it's decreased readmission rate substantially. Like the people who are
Right.
who are utilizing it. We primarily utilize it for COPD and
CHF.
and CHF are the two. Like, we see those diagnoses. Mobile health's on the radar already, and then we don't talk about houselessness as a determinant factor, but I see it quite I see it quite frequently. Just people experiencing houselessness as another high risk factor.
But there is data out there that actually shows when our readmissions went down, our mobile health referrals were up, and then when our mobile health referrals were going down, our readmissions were going up. So yeah, we can get that to you.
Yeah.
It's pretty incredible. And most of the emergency response folks have this service. It's not just limited in its paramedics.
Yeah.
Right?
Yeah.
You can do a lot more intervention right there where they're at. I'm a huge advocate. I don't think this is on, but
Treat place, they have a lot of capabilities, and I think across the board, all of those programs have shown really, really promising data with fairly limited intervention, like 3 to 4 visits on a weekly basis, and it can turn things around hugely. So,
Yeah.
good to look into, in my opinion.
Not billable for those of you. We have not figured out how to do that yet. So it's just contracts that Legacy's paying out of pocket for this.
And there,
I can say too that CareOregon and in our at our CPCCO, our Columbia Pacific CCO, and our Jackson CCO, we have a contract with paramedicine, community paramedicine, to do some of our transition work. So yeah.
there is some limitations with mobile health. They don't go everywhere because those ones that are, I think, south of Woodburn, and they don't go in Washington. They don't go basically beyond Forest Grove, I don't think.
Right.
Or past McMinnville. I think that's too far. So there's, you got to make sure before we offer it, we look at their address because it's like, oh.
So Tuolumne Fire, the Tuolumne Fire Department has a community medical service. Tammy is the go-to person for referral, and they will go out to Wilmina and Sheridan.
That's awesome.
And she's a paramedic, but she's also a chaplain.
Wow.
Which is a really cool combination.
Cool.
So that would get that, because we're in Yamhill County.
Yeah.
So we try to reserve when we use her, but she's a great option.
So are the only eligibility requirements that the person had an inpatient stay at a legacy system?
Yep.
Legacy, yeah.
And the payment accepts it.
Yeah.
Yeah. I mean, right. And I mean, I think that's one of our. We're not quite. How are we doing? We should move a little bit. Move. Okay. Move. Okay. Right.
Just one more question about mobile health. Are they feeding back, who are they feeding back the information that they get at that visit to?
to their PCP.
Oh, in like a phone call or? how do you-
Email, if their patient is part of the legacy system, if they have an LMG, PCP, they will email their case manager at that office, at that clinic. Otherwise, phone call, and then sometimes if things got really wonky, they'll email back to us and say, hey, this patient is really not doing well. We can't get a hold of family, or the doctor's not, what do you think we should do? So we kind of discuss
Good or
that.
bad, if they summary or- Okay.
So we'll try and quickly talk about barriers. I think we've kind of touched on most of these at this point. People experiencing houselessness, people dealing with addictions, just not enough beds for some of the programs. I mean, I know RCP, like I said, takes some of my complex people, but they've always got a wait list. So that's a program I wish we could expand more and more. Processes and time, like they just take time. Sometimes it's just hard to get things done in a certain amount in the time frame you're given. And then this one, oh shoot. I want to use this laser here. That's pretty sweet. There we go. The mental health needs and physical health needs, as I'm sure a lot of you are aware, there's like two silos that exist in Oregon for mental health and physical health. And if you have problems in both, neither one wants you. And you just get stuck in this. And these are the people that, again, they're like social work. You go do your magical thing. Like trying to find programs that will handle both is difficult. It's a population that is increasing in size as the baby boomer generation's coming through. I used to work for Cascadia for a long time as a program supervisor for one of the residential sites at a site where we had people with complex physical health needs as well as mental health, and just trying to find providers that can work with these people. We'll even see these people is sometimes really, really hard. So I just encourage any kind of collaboration that can exist between those two worlds to really start talking. And we see it even within Legacy. Like, sadly, Unity doesn't do IV antibiotics, which is kind of crazy. Like, we have nurses there. It's just an injection. I mean, I'm not a nurse, but that doesn't seem hard, You're all laughing at me, so maybe I'm wrong on that. Maybe it's only my paradigm. What were some of the other? We kept brainstorming as we were doing this, and there are other ones for the CCS pool. Just the amount of time. Oh, and trying to get people into their PCP appointments.
On the next slide, I don't know.
Yeah. Nope. Didn't make it.
And then, getting SNF auth. Right now, the only insurance company out there that's open on the weekend is HealthNet. So,
yeah.
That's it. Otherwise, they have to stay.
So we wouldn't rush people out on Friday if y'all would be open, just saying. These are some of the things that just blew my mind that are not barriers to discharge. Gunshot stab wounds especially. If it doesn't hit anything important, they are out the next day. Like, bar none. And these are often people that have complex social needs and need long-term care. And if I can keep them for 2 days at Emmanuel, I am thrilled. Because they're just like, they don't have, the gunshot wound will cauterize the wound. So after that, they're just like, it's a little bit of wound care, which is self-packing, and you're done. And it's like, okay. Never forget that, never mind, they were high on drugs and houseless, and they shot by their drug dealer. Like, I can't even touch that. Client questionable decision-making, I think we run into a number of times where people are disoriented, traumatized, struggling with being in the hospital, starting to show signs of dementia, but their slum score isn't low enough that we can look to a different decision maker. Variety of things go into that. And we just have to kind of chew on that and sit with that. It's like, this is a questionable discharge plan. This is not great. This is not where they should be going. And there's nothing we can do about it because they have the absolute right to say, no, I'm not going to SNF, or I'm not going to engage with that program. And so, we as social workers obviously are trying to do what we can to motivationally interview them and try and get them to the place of like maybe just contemplation of like, this might be a good thing for me. But we're limited by our time, as we talked about. So again, houselessness, not a barrier. Sometimes we discharge to the streets or the shelter because that's the only place we can send them. They won't qualify for anything else, and that sucks. That's one of the things that pisses me off. Even high risk for readmission, like there will be talks in rounds like this person's high risk for readmission. All right, well we can't make them fit into any box, so we got nothing. Fortunately, it's not often. And then I guess lastly, just wanted us to tell you all a good story to leave you on a high note. This was really hard for me because when I think about my job, I don't usually focus on the success stories because if I do a good job, I don't ever see them again. So it's really hard. I've only been doing this for about 6 months. Elizabeth's been doing this much longer. And in my 6 months, this one guy out at Mount Hood came in with pretty severe pancreatitis. I sat with him and worked with him for a couple hours, which is a ton of time in my world. If you get 2 hours of my time, that is a lot of time. But just working with him and his friends and helping to create a client-centered plan that's going to work for him, which wasn't necessarily what his friends wanted, is what helped him get clean and sober. And he called me back. I happened to be there, which was crazy, 2 months later, and he was like, hey, I'm 63 days clean and sober. And I was like, yes. Meeting with CADC, working individually, because he's just one of those people that groups aren't going to work for him. I hear all the time the doctors, send him to AA. That doesn't work for everybody. You have to have a philosophy and be willing to share your stuff very publicly for groups to work. And unfortunately, billing services work much better as a group than individual. So it's a very privileged thing to be able to get individual care in the substance use world. So.
And I just kind of wanted to add, now from the positive, some challenges, especially with trying to transition a patient out of the hospital with the appropriate, timely follow-up appointments and whatnot. It's hard. I know like legacy clinics try to keep some slots open for those patients that were in the hospital, but those get filled up really quickly. Not having a patient established with anybody, if they're open card or new with Medicaid, trying to get in within the 7 to 10 day follow-up is, I think, our biggest challenge. So it's usually realistically 4 to 6 weeks out. And so I think that's why our goal is to early assess and see these patients, they're going to need follow-up. So day one, if I don't know what their discharge date is going to be, I don't care. I'm going to already get a follow-up appointment going too. So those are some there.
It's fantastic. Really insightful, guys. This is incredibly helpful, don't you think? Yes. Excellent. Warm round of applause, please, for Elizabeth and Nate. Thank you, guys.
Thank you.